Hello, everybody. Good morning. I'm Marcela Santos. I'm a psychologist with a master's in social inclusion and disability. I was also a child caregiver for my dad, who had ALS for 16 years. He already passed. And I'm a psychologist, as I said, and I'm a volunteer at the ALS Association in Colombia called ACELA. Today, I was meant to do this presentation with Felipe Ocampo, which is one of our pals in Colombia, who's also a doctor. Unfortunately, because of a lot of challenging boundaries from his flight connection, they did not let him board with his power wheelchair on the other plane, the connection plane. He decided to go back to Colombia. So he won't be joining us this year. So this year, I'm going to try to make all the questions for him in the presentations, just like last year. So today, I'm going to talk to you about the challenging boundaries for PALs in Colombia and their caregivers. A little bit about us. ACELA was founded in 2008 by a person with ALS, Orlando Ruiz. We are members of the Alliance since 2010, and our mission is to promote the quality of life and well-being of PALs and CALs in Colombia through information, strategic alliances, and I'm going to show you a little bit further how we do that. We are 100% volunteer-based. All of our volunteers are caregivers or are patients with ALS. Well, most of them. We started getting people that were not related to ALS, but they want to volunteer. We started being 4 volunteers, and now it's 23. So we're doing a pretty good job. A little bit of our numbers. We have a population in Colombia with an O, not a U, please. 51.52 million people. Of that, we have an estimated of 3,000 people living with ALS in Colombia. And we have a registry in the health ministry with the doctors when they do the diagnosis. We have reported for 2021, it was 1,525 patients. In ACELA, since we started doing our own registry of people that get affiliated to ACELA, we have 534 patients. A little bit about how the health system works in Colombia. So almost 95% of Colombians have a public insurance, and they have a coverage of services. Of that 95%, it's divided between 54.8% are subsidized. That means they do not have to pay a monthly service to get all the a monthly pay to get all the coverages. And 44.9%, it's a contributory regime, which means they have to do a monthly contribution depending on their salary base, and they have to do co-pays for the services they access. So if they go to a medical appointment, they're going to pay $7. If they go to a therapy session, it's going to be $5. It depends on, on their income. As you can see, it's supposed to be the other way around. It's supposed to be 60% and 40%, so that the contributory regime can actually subsidize the other regime. It's upside down, so that means there's a deficit in money in Colombia in the healthcare system. However, the good thing is, independently of where you are in the regime, you have the same access to the services and plans as a patient living with ALS. For example, and you also have the optional private health insurance. For example, a patient with ALS that requires rehabilitation can access care services at home, independent of if they're in the contributory or subsidized regime. However, the fact that they do it at home depends on their location. If they're in a rural area where there are no care services unit that provide that service remotely, it's really hard. But for patients, for example, with tracheogastro feeding tube, which is Gudjon's question yesterday, it is easier to get a nurse at home because there's a medical need for them. It's not a caregiver need, it's a nurse need, which I'm going to explain later. And so they do, this is Orlando on most of the photos. He's showing us the respiratory therapist, the physical therapist. They go to their house. This guy right here with the 4 nurses, that's my dad. In his case, he had 24-hour nurses provided by the insurance all the time. So they provided 2 of them, well, actually 3, because they need to do days, nights, and recesses, breaks. And then the only condition is that when you get a nurse in Colombia paid by the insurance, you have to ensure there's a caregiver, family caregiver, or someone at the house at all times, plus the nurse. So the patient can never be alone only with the nurse. That is difficult for families that have to work. If it's a family of two and the other person has to provide and the other one has ALS, it's hard to find someone else to be at the house all the time. So that's one of our main challenges. However, in Colombia, we're very family oriented, so we all like help each other. So this is a little bit of our patients, one of the photos they shared to us. Depending on the area we are, the patients are located, there will be economic disparities in the context, and that will, of course, impact the quality of life of patients with ALS. That is nothing new for you all, and it's nothing new for us. For example, if you live in a house like the person on the left on top with the red shirt, his house doesn't have flooring, like proper flooring. The insurance company would say it's not proper for home care services to go to his house because it's not sanitary. So this poses a challenges for us, because that patient means the most probably thing is if he gets ventilated and has to go, has chronic care, they would have to put him in a chronic care clinic, which is usually in the capital cities, not in the rural areas. Transportation is not accessible in Colombia, so patients have to basically figure out how they do. They usually just ask people to carry them and help them out. You can access transportation to the hospital when you're ventilated. If you have to go see your doctor or whatever, they can book an ambulance or transportation for you specifically. But the problem is for patients that have that intermediate. They're not fully disabled mobility-wise, but they still need help getting there. When you get home care services, again, my dad and my mom on Colombian game day, you get the medical bed, the nurses, the oxygen tanks, I forget the name. Bueno, all the things you need are provided, no charge for the patients. It's also important to notice that patients in Colombia with ALS are protected by a law, orphan disease law. So we have a little bit more of guarantees of health care services. And I don't know how much my time is. Oh, I'm already in the half. Okay, so I forgot what I was saying. They are exempt of copay payments if you're in a rehabilitation that is going to take forever. So usually if you sprain your ankle, you pay a copay. If you're in a contributory system, you pay a copay because you're going to, 10 physical therapies. For a patient with ALS, they're going to need PT for the rest of their lives. So in those cases, you have to have a legal situation, and you can solicit that you are exempt of that. This was going to be presented by Felipe. I'm going to try my best to honor him. These are the regular boundaries PALS face in the Colombian context. Of course, accessibility issues. Felipe showed us this is a high economic status in Colombia, and there are no accessible pathways or boardwalks. The bathrooms, of course, they don't have the accessibility options. And if you live in rural areas like the photo on the right, of course, there's going to be limited access to everything, every service and transportation. The long waiting times depends on the insurance you have. For example, in order for a Colombian to see a specialist, they would have to go, if they're in the regular insurance, they would have to go to a primary care physician. Then in 3 months, they would get an appointment with a neurologist. That neurologist would send him to test, and then they will get diagnosed. So it's like almost, more than a year time process. Of course, there's discrimination and attitudinal barriers, a limited access to genetic counseling and testing. Only the Roosevelt Institute is doing genetic testing in Colombia, and we only get it for patients with ALS that are diagnosed, no family members, nothing. But there is a good genetic counseling offered by that hospital. And we do not have, we'll have limited access to augmentative and alternative communication. What are our strategies in Marcela? So in order to diminish the times between the patient gets all of the things they need, the Riluzole, the wheelchairs, walking aids, eye gaze communication, what we do is we receive donations from family members of patients that have passed or are not using anything anymore. And we have a storage room, and we lend them free of cost to all of our patients nationwide. that serves as a solution, an immediate solution for instead of waiting 6 months to get the wheelchair, we're going to give it to you today. We have advice and support from our volunteers that have lived the experience of ALS. We hire patients and their services. For example, this man right here is a carpenter. He just got diagnosed with ALS, and he offered his services to us, and we bought the candles, wooden candle holders, and we hired his services. We have caregiver support groups. We have done strategic alliances with legal support. We have lawyers that work for free for us, for our patients, with a university agreement we did. We have received donations from the ALS Association of eye gaze devices, which I will talk to you in the APF if you guys can join us. And we have, of course, the ALS clinic. The only ALS clinic in Colombia is in Bogota with the Roosevelt Institute, and we have an alliance with them where the patients that are in Marcela and access to this package, they get a personalized call center with ALS, 10% to 50% discount in the majority of services if they have to go to them as a private and not through their insurance, and telemedicine appointments with Dr. Marta Peña, who is also here. Okay, I don't know if you guys remember this, but 11 minutes, okay. I don't know if you remember this, but a few years ago we presented that since 2008, ACELA has been doing public advocacy for caregivers. Finally, this year in 24/7, which is July 24th, which is the 24/7 time, we have a law in Colombia for caregivers. It's recognizes that caregivers as a position. Actually, it's going to have a caregiver registry. People that are in that registry will have access to flexible work hours and remote jobs. They're going to have entrepreneurship opportunities. There's going to be a standardization of the profile, as I said, and there's going to be education for that profile, so people can actually get trained as official caregivers. And they have specific access to healthcare services like mental health and physical health, and now there are social programs of assistance. And that's us in the Congress when we were to speak there. And now I want to show you the video. I don't know, how do I play that? Thank you. A little bit of context real quick. Patients that are ventilated in Colombia cannot leave their houses or clinics. It's prohibited. They say the insurance of the machine only covers in the home place or in the clinic. So we have to go around that. My dad we made up, he had an appointment. So we booked an ambulance and we actually took him to our company and he said goodbye to all of his workers. They said dogs cannot go into the clinic, into a chronic care unit. So we just took him outside of the clinic and to the dogs to him. That's the way that Colombians, we solve problems. Like, we don't take no for an answer. We will bend the rules. And that's what make us so resilient and adapting and overcoming boundaries. The resilience and determination and resourcefulness demonstrated by our patients in Colombia resonate with the global and fight against ALS. And by sharing our stories, we hope to inspire you to break down your own challenges. And together we can turn these stories and struggles into narratives of global solidarity and progress. Thank you.
Thank you, Marcela. Are there any questions for Marcela? Yes?
Okay, thank you, Marcela, for that presentation. Thank you so much. I was curious because Argentina and Colombia has several similarities in terms of population. We also have that geographical diversity as well. So I was wondering, how do you reach the rest of the population? I saw your numbers. I know that there are other ALS organizations in Colombia, but how do you divide all those approximately 3,000 people with ALS? And is there a geographical boundary to reach those people?
Okay. So it is hard. Most patients in rural areas don't even get diagnosed before they die, because the access to specialists, and there's a lot of ignorance, or not ignorance, there's limited knowledge of ALS in the primary care physicians. So unless a neurologist sees them, it's going to be hard to get diagnosed. So it is hard. We try to do awareness campaigns when we do the ALS Day. This is one of the walks, for example, we did, and we go on all the national televisions. We are in every interview, radio interview, everything we can, so that people can actually notice us and know that we exist. And when we do these strategies of communications, a lot of people come to us like, oh, finally, somebody has ALS in Colombia and they can help us. So that's how we reach them. And of course, through our Instagram, Facebook, all of that. And we do support groups in every city. We fly out to every city and we do our support groups, and that's where we get even more people to come in.
Yeah, question?
In one of your early slides, you showed that about 5% of the people in Colombia don't have insurance. And unfortunately, in the U.S., that's also the case, is that a lot of people don't have insurance. I'm wondering how those remaining 5% are access care in Colombia.
So usually those people are the ones that are so dispersed, they're not even registered in the basic programs of the country, because 95% is a lot of people insured. Those people would access the health system through a special regime. They would get access to emergency, like any ER, they would get it, and once they're there, they would automatically enter the subsidized program if it's showed that they do not, of course, have the money to contribute. That happens, for example, when there is foreigners, Venezuelans, or people that are migrating to Colombia. They don't have an insurance, they don't have an ID. They would immediately be helped and assisted so that they can get the ER and then included in a subsidized program.
No more questions?
I think Richard.
Oh, yeah, there.
Yeah, my name's Richard. I'm from London, England, although I wish it was London, Canada. I was wondering, is in terms of access to technology, is access to technology only limited to the big cities like Bogota, or can people get eye gaze, that kind of stuff? And the second part of my question is for kind of speech therapists. Is there much awareness of ALS amongst speech therapists, and are speech therapists kind of covered around the country?
I'm so glad you asked that because the presentation I'll be talking about at APF is about communication barriers that we're having. Speech therapists do not know about communication technology and eye gaze. It's very difficult. We communicate through boards that have a letter, and with the movement of the eyes, patients can communicate. We have introduced, through the ALS Association's donation of eye gaze, we have introduced that in Colombia. People in Colombia can access eye gaze communication through the insurance with, of course, a lot of fighting, but they can get it. However, there's no one to train them in it. There's no one to help them out with it. There's no voice banking. So that's why we are doing what we're doing. If you were here yesterday, we talked about the pilot we're doing in Colombia. It's actually to access and provide this to our patients in Colombia because we do not have that kind of technology. We do not have power wheelchairs, for example. The one Felipe has was when he lived in the U.S., the ALS Association gave it that to him, or his insurance in the U.S. gave that to him. That's not a Colombian thing.
Okay, so thank you, Marcela.
Thank you. See you in Canada next year.